All right, so today we're going to be talking about managing diabetes in CKD. We're going to be summarizing the new guidelines that have been put out by KDIGO. That's what we're going to be doing. My name's Isaac Wade. Let's get into the presentation. This presentation, who is it for? It's for your healthcare providers. I'm going to be using a lot of jargon in this presentation, and I apologize for that. So it's going to be difficult to understand a lot of the things that I'm talking about unless you have a good understanding of diabetes and drugs that treat diabetes and all the different medical abbreviations and jargon I'm going to be using. And for that reason, I feel like healthcare providers would benefit the most from this information. This is not medical advice. If you're looking for medical advice, go see your doctor. Do not watch this video. Okay, so let's get straight into it. I've got a question for you guys. And my question for you guys is, what are the leading causes of end-stage renal disease? That's defined as kidney failure that requires renal transplantation or dialysis. So what are the leading causes of this? And you can take your time. I'm just going to move on. The leading causes are diabetes, hypertension, and glomerulonephritis, right? Those diseases are what cause people to develop end-stage renal disease. And today I'm going to be focusing my attention specifically on diabetes, which is the leading cause. First of all, let's take a look at the prognosis of individuals with diabetes on dialysis, and let's compare their prognosis to individuals who do not have diabetes who are on dialysis. So here we've got a chart. This data comes from Ontario, I believe, and it pretty much tells us the chances of survival of dialysis patients by age and also by whether or not they have diabetes. So those are the two different slices that they looked at in this data. And what you can see is that if you compare the individuals up top who do not have diabetes with the individuals at the bottom who do have diabetes, their 10-year survival prognosis is much more grim. If you have diabetes, your chances of surviving 10 years on dialysis are not very high compared to if you did not have diabetes. So you can see prognosis very grim, especially for individuals with diabetes. And for that reason, we really want to delay the amount of time that it takes someone with diabetes to have end-stage renal disease and to require dialysis. So I've got another question for you guys. And my second question for you guys is, what are your biggest concerns and questions when it comes to treating a patient with comorbid CKD with diabetes? What kind of things do you want to think about for these patients? And again, take your time. You can pause the video, use that noggin, and I'm going to move on. So this is a figure that was put out by KDIGO in their guidelines, and I believe this figure does a really good job summarizing all of the different factors that we should be looking to optimize in these types of patients. So again, this is from their brand new guidelines, and their guidelines come at a really important point in diabetes management. There have been a whole bunch of new technologies that have been invented, whether that's new pharmacotherapy, whether that's new ways of measuring blood glucose, but lots of new technology is coming out in this field. And this is a really excellent, amazing time for KDIGO to put out a guideline on this topic. Again, this is the figure. They've got all the different factors we should be considering over here. And I want to focus your attention specifically on these bottom factors first. So these types of factors are factors that we should be considering for every single patient that has CKD with diabetes, no matter what. Blood pressure, usually it's going to be less than 130/80. That's going to be our target. And when it comes to managing blood pressure, you should think about going with a RAS blockade, like an angiotensin receptor blocker or an ACE inhibitor. One of those drugs is going to be ideal. The reason being is that the research demonstrates that these types of drugs effectively delay the progression of kidney disease and help to lower the amount of albumin that's leaking out of the urine. So albuminuria being a really good indicator of how quickly the CKD is progressing. So go with a RAS blockade. It's not recommended to combine an ACE inhibitor with an ARB, by the way. Kind of have some safety issues without very much evidence demonstrating that it's more efficacious than either agent on its own. So not recommended to combine them. Lipid management. This is really important. A lot of these patients are going to be at high risk of cardiovascular disease. Usually a statin is going to be indicated for these patients. If you have a patient who does not have a statin, you should probably do some digging and figure out why that patient is not using a statin type medication. Exercise is super important. 150 minutes of aerobic exercise, it's what is recommended for these types of patients. If you look at the Canadian Diabetes Guideline as well, they do recommend some resistance exercises as well. So you could consider giving that to your patient if they can tolerate that. Again, assuming that they can tolerate this type of exercise, recommend 150 minutes of aerobic exercise per week. Diet, let's talk about diet now. The diet that's recommended, relatively low protein diet, low sodium diet is what's recommended. The dietary advice is pretty straightforward. I'll just read it out for you guys now. Individualized diet high in vegetables, fruits, whole grains, fibers, legumes, plant-based proteins, unsaturated fats and nuts, and lower in processed meats, refined carbohydrates, and sweetened beverages. So the dietary advice is pretty straightforward. No surprises here. Couple different biomarkers that are highly influenced by the diet of your patients are going to be the phosphate, the potassium, and then the blood sugars, obviously. So the phosphate and the potassium and the blood sugars, these biomarkers can actually be managed. They can be managed with pharmacotherapy, like if you were to add a phosphate binder or ketoxylate. However, you can manage them with dietary changes as well, which is why having your patient talk to a dietitian is always a good idea for this type of population. And lastly, healthy foods. So if you're the type of practitioner who loves to give out dietary advice, the dietary requirements of a patient with kidney disease is much, much different than those of someone who does not have kidney disease. Healthy foods, quote unquote, healthy foods for regular people may not be healthy for your patient with kidney disease. And for that reason, unless you are super confident about your advice, or unless you're a dietitian with experience in this field, it would probably be better to refer your patient to a dietitian and to be really careful about the type of dietary advice you provide. So smoking, let's talk about smoking. Smoking is bad for diabetes. Smoking is bad for CKD. We can assume smoking is bad for someone who has both diabetes and CKD. So we always want our patients to quit smoking when they can. Always talk to your patients about quitting, ask if they're ready to quit. If they are ready to quit, think about making a quit plan with your patient. And when it comes to pharmacotherapy, quitting smoking is incredibly difficult. The cards are stacked against you if you're trying to quit, and chances are you're not going to be able to, right? So pharmacotherapy, these are tools in the toolbox that can help to improve your patient's chances of quitting smoking. So what kind of tools do we have here? Varenicline, Champix, we can use that. Nicotine replacement therapy, such as nicotine patches, nicotine gums, all of those things we can use as well. Bupropion or Wellbutrin, we can think about using that as well. In terms of coverage, if you're looking for something that's covered, if you have a patient who has government coverage, I would probably go with Varenicline in Ontario. You can get this one covered by the government. It's the LU code lasts for about 12 weeks for each year. So you can give them the LU code once a year, and then each year it lasts for 12 weeks. They get a short course of Champix pretty much. So LU code 423, and you can prescribe Varenicline, and that will be covered by the Ontario Drug Benefits. However, if they've already used Varenicline within the last 12 months, then you might have to wait a little while until you can use that LU code again. Just something to consider. And yeah, that's pretty much all of the major things that we should be considering. The next ones I'm going to be talking about really form the meat and potatoes of my presentation, and those are glycemic control and Sglt2 inhibitors. So that's what I'm going to be focusing on here. And I've got another question for you guys. My question for you guys is, what do you guys think is good glycemic control? A1c less than 6, A1c less than 7, A1c less than 8. What's good glycemic control? Again, pause the video, use that noggin, think about something. I'm going to move on. And this is a trick question. So the ideal glycemic control for your patient is really going to depend on a whole bunch of different factors. If you have a younger patient, someone who has a longer life expectancy, who's able to manage their own medications, who is able to recognize whether or not they are experiencing hypoglycemia, you could tighten up that glycemic control. That type of patient is probably going to benefit from having a tighter glycemic control, so like A1c less than 6.5. However, if you have an older patient, someone with a lower life expectancy, someone who's on a lot of medications that might cause hypoglycemia, like insulin and sulfonylureas, if they have difficulty recognizing when they are experiencing hypoglycemia, or if they're unable to treat themselves, in that case, they would benefit from having looser glycemic targets. So like A1c less than 8, because the risks of hypoglycemia is going to outweigh the benefits that they would derive from keeping their blood sugars under control, essentially. Also, on this slide, I also want to point out something. As CKD progresses, the A1c actually becomes a less accurate measure of glycemic control. That's because that as CKD progresses, red blood cells tend to turn over, and in turn, that leads to the A1c actually under predicting the actual glycemic control. So it underestimates the true glycemic control of your patient. You might have a patient with, let's say, the glomerular filtration rate, or GFR. Let's say their GFR is like 17. On paper, they might have a A1c of 7, which is amazing. That's a target for most people, right? But in reality, their true A1c might actually be closer to 8 or 8.5. And that can be very misleading because you think that they have their sugars under control, but in reality, they actually don't. And we can't tell whether or not they do because the A1c simply is not an accurate measure for that specific patient. So just something to consider. We are moving past this, though. We're starting to get more into continuous blood glucose monitoring. I think that is really going to be the solution to this type of problem. And so let's talk about the future of blood glucose monitoring for a second. So back in the past, like even a year ago or 2 years ago, most patients that you saw were using your classic glucometer, right? You had your test strips, you had your lancets, you pricked your finger, you put the test strip in the machine, you put some blood on that test strip, and it gave you a reading. That is kind of inconvenient. You need to bring a sharps container with you everywhere. You're constantly drawing blood. You're constantly poking holes in your fingers. It's just simply not very convenient. So now we have the Freestyle Libre. This device has been covered by the Ontario Drug Benefits for a little while, so lots and lots of patients are using it now. The way that one works, you have a sensor, you stick it to the back of your arm, and then you have a reader, and you just read the sensor every once in a while, and then it gives you a reading. So it's much, much more convenient than the glucometer. It does have some downsides, though. It's not going to be as accurate as your classic glucometer. If you have a patient who's experiencing acute hypoglycemia and you need a quick and accurate reading of their blood sugars, you're going to want to go with your classic glucometer. But for the majority of patients who do not experience that much hypoglycemia, who have their blood sugars relatively well under control, this type of device is going to be a lifesaver when it comes to actually measuring their sugars. So that's something I wanted to talk about. Freestyle Libre. The Freestyle Libre is great. I would say it's not a true continuous blood glucose monitor. So when it comes to true continuous blood glucose monitoring, we're talking more about something like the Dexcom 6, right? The Dexcom 6, this is an awesome device. You can just stick it on yourself. It automatically will measure your blood sugars every 5 minutes or something, and it'll send that information to your phone, and then it'll plot your blood sugars on a graph versus time. And just by looking at the area up under that curve, you can have a really, really great estimate, a very accurate estimate of your average blood sugar control. So Dexcom 6 is amazing. It'll vibrate. It'll let you know if you're going to experience hypoglycemia. It'll let you know if you're going to experience hyperglycemia. Really, really excellent device. I think in the future, when it comes to assessing glycemic control, especially in CKD patients, we're going to have to use something like a Dexcom 6. That's going to be really amazing, a very useful tool. And for other diabetics as well, it's going to be a really great tool for achieving tighter glycemic control without necessarily provoking more hypoglycemic episodes. So just a safer way of controlling your blood sugars, in my opinion, when we start to have more people using this brand new technology, the Dexcom 6. So not covered yet, probably very expensive. I'm not exactly sure how much it costs, but I'm guessing it is very expensive. Hopefully one of these types of devices gets covered by the Ontario Drug Benefits. Eventually that would be absolutely amazing. Okay, so question 4, I've got another question for you guys. My question is, what are the biggest barriers that are preventing your patients from achieving their glycemic targets? Why is it that despite our patients trying so hard, we see a lot of patients with A1Cs above 10, double-digit A1Cs. We see patients with fasting blood sugars in the 20s. Why is that? Why can't people keep those sugars under control? And, think about that. Think about that. Pause the video, do what you must. I'm just going to move on. And for myself, in my experience, these are the biggest factors that are preventing our patients from achieving good glycemic control. So, first, hypoglycemia, right? Insulin, sulfonylureas, they cause hypoglycemia. Hypoglycemia is really dangerous. For patients who have a history of hypoglycemia, we're not going to want to move their sugars as low, right? Because that's dangerous. So hypoglycemia is a big barrier preventing people from keeping their sugars under control. Weight gain as well. When you prescribe someone insulin, a lot of them are thinking, why am I going to take something that's going to make me gain weight if they have type 2 diabetes, for example? That doesn't make any sense. That sounds super counterintuitive. And if they do take insulin and they do end up gaining 30 pounds, that is not going to do any favors for their blood sugar control either. So weight gain's another big one. Needles, no one likes needles. Price, these drugs very expensive, although there are lots of new developments in diabetes drugs that are, they make improvements in terms of efficacy and safety and convenience of all of these different treatments and devices, but they are expensive, right? That is the caveat of these new technologies. So they're all very expensive. Not very many generic options are available. And for that reason, price is a pretty big barrier, especially for individuals that don't have coverage. In my experience, the coverage generally covers the majority of diabetes drugs, but for someone who does not have coverage, it is a big, big problem. Kidney function, as your kidney function declines, the number of options you have in terms of diabetes drugs goes down. So kidney function is a big problem. And health literacy. Diabetes, incredibly difficult, complicated disease. Often people with diabetes and CKD have other comorbidities as well. So very, very, very complicated for patients to manage themselves. But what I want to talk to you guys about today is that a lot of these barriers that I'm talking about, a lot of them can be overcome by choosing the right drug. And today we're going to be going through an algorithm that KDIGO put out that kind of gives us an idea of which drugs we should be choosing and when. So which drugs should we be using? That's a great question. First one, lifestyle, not a drug, lifestyle. Physical activity, nutrition, weight loss, lifestyle treatments generally are going to have your best bang for your buck, the best risk to benefit ratio. Next, first-line therapy, which, by the way, you should probably be prescribing to everyone who can tolerate these types of drugs, but metformin and Sglt2 inhibitors. Metformin, keep in mind, look at that kidney function over here. And metformin has always been first line, right? It's no surprises here. Metformin has cardiovascular benefits. Metformin does not cause weight gain. Metformin has excellent safety and efficacy data to support it. Lots and lots and lots of data to support metformin. My question is, why do we have Sglt2 inhibitors? So where did the Sglt2 inhibitors come from? They came very recently. And the reason why we have Sglt2 inhibitors as a first-line therapy for CKD in diabetes, or diabetes in CKD, is because of a lot of new research that's been coming out. So there have been a whole bunch of different studies that have demonstrated that Sglt2 inhibitors actually decrease the progression of CKD. So they are kidney protective. And they're kidney protective beyond the glycemic control that they offer. So if you take two people, they both have A1Cs of 7, the individual who is on the Sglt2 inhibitor is probably going to have a slower decline of their kidney disease compared to the individual who is not. Maybe that individual is using a sulfonylurea, or maybe they're using a Dpp-4 inhibitor, but all things being equal in terms of glycemic control, the individual with the Sglt2 inhibitor is going to have better functioning kidneys. So let's talk about that right now. There are a whole bunch of studies. I'm just going to focus on one of the newer ones. So this one was DAPA-CKD, dapagliflozin in chronic kidney disease. And the way that they conducted the study is they had N was 4,300, randomized to treatment and control. Inclusion criteria, let's take a look over here. So I want to point out the GFR inclusion criteria. Right? So it's 25 to 75. And this is something that's new. We didn't used to give Sglt2 inhibitors to people with kidneys that didn't work so well. So I just wanted to point that out. You're going to see a lot of prescribers prescribing these types of agents in individuals with kidneys that are not working very well. That is completely normal. They've studied these types of drugs in individuals with really bad kidney function. And for the most part, they're pretty safe. So inclusion criteria, GFR 25 to 75, albumin to creatinine ratio. You can see these patients are leaking protein, a lot of protein actually. So that is one of the inclusion criteria. And then RAS blockade as well. So they would be on an angiotensin receptor blocker or an ACE inhibitor. One thing that is not an inclusion criteria is having diabetes. Notice that there. So 1/3 of the patients in the study actually did not even have diabetes. They just had CKD and they were just put in the study anyway. So let's see what happened. The primary outcome was a bad outcome. It was a composite of sustained decline in eGFR of at least 50%, end-stage renal disease, or death from renal or cardiovascular causes. So bad primary outcome. Let's take a look at the data over here. So left side over here, we have cumulative incidence of this bad primary outcome on the y-axis, and then we have months since randomization on the x-axis. And what we see here is when we compare the placebo group to the dapagliflozin group, it looks like the dapagliflozin group is doing significantly better than the placebo group. They have a much, much lower incidence of this primary outcome. So much so that it is statistically significant. If we take a look, hazard ratio 0.6, confidence interval, 95% confidence interval, much, much lower than 1. So definitely statistically significant. And so much so that they had to end the study early. Like a lot of these types of studies, they ended it after 2 years. That was because of the clear efficacy and safety of the dapagliflozin as a treatment to prevent progression of chronic kidney disease. At that point, at 2.4 years, it simply would not be ethical to continue running the study based on how clear it was that dapagliflozin was kidney protective, right? So in conclusion of the authors, pretty straightforward. Among people with CKD, whether or not they had diabetes, the risk of the bad primary outcome was lower in the dapagliflozin group compared to the placebo group. So, and because of studies like DAPA-CKD, and there are a couple of other ones, more and more prescribers are starting to use Sglt2 inhibitors for their kidney protective effects, not only for their anti-hyperglycemic effects. So now let's just do a quick review of Sglt2 inhibitors. So this class of drug, they're called the gliflozins, right? We have our empagliflozin, our canagliflozin, our dapagliflozin, however you guys want to pronounce it, but they're the gliflozins. How do they work? They cause our patients to pee out sugar. They prevent the reuptake of sugar from the proximal tubule of the nephron. So that's how they work. And then sugar doesn't get reabsorbed, so it just gets excreted. When you start an Sglt2 inhibitor, it might cause some reversible decline in GFR. It's something to point out. So if you have a patient and you're starting an Sglt2 inhibitor for its kidney protective effect, the next time you see that patient and you take a look at their labs, their creatinine clearance, their GFR might actually decline by a couple points. And that's something that's completely normal. That is not something to worry about. It happens all the time. So it does cause some reversible eGFR decline on initiation. It is a diabetes drug, right? So it does have a moderate A1c lowering effect. If you have a patient who needs their A1c lowered by like 3 points, it's not going to do that. It's not going to do any miracles here, but it does have some good A1c lowering effect as well. It does cause some weight loss, thankfully. So it doesn't cause weight gain. It actually causes weight loss, 2 to 3 kilos to be exact. Not as much weight loss as something like a GLP-1 receptor agonist, but it is pretty good with respect to weight loss. Diuresis, right? So you're peeing out sugar. What follows sugar? Water is going to follow sugar by osmosis. So you're going to be peeing more. That's going to lead to a lower intravascular volume, and that's going to lower blood pressure. So monitor hypotension might be a good thing if your patient has hypertension that isn't quite controlled. Lastly, it does increase the risk of ketoacidosis, unfortunately, so monitor for that. And it is fairly expensive. Fortunately, it is covered by the Ontario drug benefits. And it's important to note, Sglt2 inhibitors, these are a sick day medications. If your patient is sick, if they're unable to consume adequate amounts of fluid or food, or if they're vomiting or throwing up, you're going to want to hold these medications along with your diuretics and your RAS blockade drugs and your metformin and your sulfonylureas. These are another type of drug that you're going to want to hold on sick days. Okay, so that leads us to the third category. So let's say you have a patient and you've given them metformin, you've put them on an Sglt2 inhibitor, and their A1c is 8.2. So obviously not good enough for the majority of patients. We're going to have to think about adding on another type of drug. So which drug do we choose in this case? That's a really great question. And the answer is that it depends. It depends on a whole bunch of different factors, the type of drug that you should prescribe. So these are all the different drugs we're going to be talking about. I've crossed out the glitazones, and I've also crossed out the alpha glucosidase inhibitors simply because they're not really prescribed as often. So I don't really think that you'll have as much benefit from knowing about these types of drugs. So I'm just not going to talk about them. And this figure in the middle, this another one by KDIGO, it kind of talks about all the different factors that we should be considering for these types of patients when it comes to choosing an additional anti-hyperglycemic agent after we've already exhausted metformin and our Sglt2 inhibitor. This figure is kind of difficult to interpret, or at least I found it difficult to interpret. So I'm just going to make I just made some slides about it. We'll talk about it now. So first of all, let's talk about avoiding hypoglycemia, one of the most important factors when it comes to choosing a diabetes drug. Because if we have a patient who has excellent glycemic control, if their sugars decline all the way down to 2.2 and they wind up in a coma, what good did their glycemic control do then, right? So avoiding hypoglycemia should always take priority over treating hyperglycemia. Insulin and sulfonylureas, these are the two biggest offenders when it comes to causing hypoglycemia. The other drugs, the other classes, Dpp-4, GLP-1, Sglt2, metformin, these drugs have less chance of causing hypoglycemia, although they may contribute to hypoglycemia if the patient is also taking insulin or a sulfonylurea. Like if you add on one of these drugs, it might increase their chances of having. It might contribute a little bit towards that hypoglycemic episode. Okay, so let's talk now about treating hyperglycemia. When it comes to treating hyperglycemia, again, we're going to be measuring glycemia by A1c, so A1c lowering effects. The best drug for A1c lowering is obviously going to be insulin. You can pretty much titrate that to infinity, and these days we have so many different types of insulin. Yeah, we really have a really great, lots and lots of different insulins to choose from these days. So insulin is going to be the best for lowering A1c. Next in line, we have our sulfonylureas and our GLP-1 receptor agonists. And then lastly, okay A1c lowering, we've got our metformin, our Dpp-4 inhibitors, and our Sglt2 inhibitors as well. And again, this is a very, I'm just painting this picture with very broad strokes here. So huge generalizations. You might find examples where metformin lowers A1c more than glycoside or vice versa. I'm just saying, by the average, generally speaking, a sulfonylurea is going to lower your sugars more than a Dpp-4 inhibitor, right? So that's what you should know when it comes to treating hyperglycemia. Okay, so let's now talk about cardiovascular protection. So our patients who are diabetics have a greater risk of cardiovascular disease. Our patients with CKD have a greater risk of cardiovascular disease. Our patients with both CKD and diabetes have a much greater risk of cardiovascular disease. So we're going to be really interested in choosing an agent with demonstrated cardiovascular protection that extends beyond simply the benefits that they give us by their glycemic lowering effects, right? So some of these drugs actually provide additional cardiovascular protection. That's what we're going to be looking for here. And the way that we're measuring cardiovascular protection is by MACE. MACE stands for Major Adverse Cardiovascular Event, and we're going to be looking specifically for agents that help to lower MACE. So first of all, let's take a look at Sglt2 inhibitors. These drugs all lower MACE, as you can see over here. So these drugs are cardioprotective. Let's take a look at our GLP-1 receptor agonists. Most of these drugs do lower MACE. Some of them do not, most of them do. So we're going to want to make sure that we prescribe a drug that helps to lower MACE. For example, liraglutide, semaglutide, albiglutide, and dulaglutide. So we're probably going to want to prescribe one of those agents. I don't really see the point of prescribing a GLP-1 receptor agonist that doesn't provide cardiovascular protection, but if you disagree, then let me know. When it comes to Dpp-4 inhibitors, these are really great drugs, very safe, very efficacious. These types of drugs are not going to provide any cardiovascular benefits, so don't consider prescribing a Dpp-4 inhibitor if cardiovascular protection is what you're looking for. Okay, so we've talked about cardiovascular protection. Now let's talk about which drugs are appropriate to prescribe at different renal functions. So like I said earlier, the renal function of your patient is going to have a major impact on the different tools in the toolbox that you can use for lowering A1c. First of all, let's talk about metformin. Metformin, amazing drug, very safe, very efficacious. You got to use caution with metformin. Once your patient is below 60 or below 45, you're going to want to start to think in terms of GFR, you're going to want to start to think about lowering the dose from 2 grams a day to maybe like 1 gram a day divided dosing. And then once they're below 30, you should probably consider discontinuing metformin. You might find nephrologists who continue it, but for primary caregiver, for primary healthcare providers, it might be a good idea to think about discontinuing it at 30. Dpp-4 inhibitors, mostly safe. You can see over here, a lot of them you can use at the lower renal functions. For example, pretty much all of them you can use at low renal functions. It's just saxagliptin where we got to discontinue it below 15. GLP-1 receptor agonists, we got to be careful with. Some of them you can one of them you can continue to use, the dulaglutide, and then some of them you're supposed to discontinue below 30 or below 15. Sulfonylureas, you can continue some of them. It's not really recommended. They're going to start accumulating and they're going to increase the chance of your patient experience hypoglycemia. So not really recommended at the lower GFRs, but you can see over here, repaglinide you can continue to use. Just be careful. Sglt2 inhibitors, these types of drugs, this particular class of drug, I believe that this graph is a little bit outdated based on the newer research that we have now. We could probably consider prescribing them at lower GFRs. You're definitely going to find people prescribing them at very low GFR. So ignore the Sglt2 inhibitors. Insulin's okay for everyone. You just got to watch for hypoglycemia, to be honest with the insulin. And then, so nephrology, this is an art. This is not a science, not necessarily. It's more of an art. So you're going to see a lot of doctors, a lot of nephrologists that are prescribing medications below their recommended GFRs based on new research, based on their clinical experience. So I wouldn't be surprised if there are certain patients who are on different drugs that are not recommended for their kidney function. Just make sure to monitor these patients closely. Let's talk about financial considerations and coverage now. So no insurance, no problem, right? When it comes to a patient who does not have great coverage options, you're going to want to consider an older agent like a sulfonylurea, metformin, or an older insulin. These drugs are all relatively inexpensive. When it comes to the newer drugs, these drugs are all more expensive. Not as many generic options are available. So like our GLP-1 or Dpp-4 our Sglt2 or insulins, these drugs are all very expensive. And the costs that I have over here are the monthly estimated costs in Ontario. If you live in the States, just take this number, multiply it by 4, and add on the price of an antidepressant and some psychotherapy. And then that'll give you a better estimate of the true cost of these medications if you're in the States. Fortunately, most of these drugs are covered by the Ontario Drug Benefits. Okay, so weight gain, weight loss, insulin and sulfonylureas, any type of drug that increases insulin is going to cause weight gain. So those ones cause weight gain. Metformin, Dpp-4 inhibitors, those drugs are weight neutral. GLP-1s and Sglt2s, these drugs cause weight loss. GLP-1s a little bit more than the Sglt2s, to be honest. Injections, no one likes injecting things. GLP-1s and insulin, these drugs you got to inject subcutaneously. Insulin, you can inject either daily or multiple times a day, depending on what kind of regimen your endocrinologist has you on. GLP-1 receptor agonists generally are going to be injected either once a day or once a week, if you're using Somagglutide, for example. Oral Somagglutide, what the heck? So this is a recent development in diabetes medication, oral semaglutide called Ribelsus. That's what it looks like. And this one is a pill that you take. So it is GLP-1 receptor agonist, like I said, almost always given by injection, oral semaglutide. They figured it out. They figured out how to turn it into an oral dosing form. Unfortunately, it has pretty specific administration requirements. So you got to take it 30 minutes before eating with exactly 100 milliliters of water. You can't have it with 200 mils. You can't have it with 50 mils. It's got to be 100 mils of water 30 minutes before eating. What does it do? Fortunately, like its injectable brother, it causes weight loss. Unlike the injectable version of semaglutide, it does not have demonstrated cardiovascular benefits, unfortunately. If you take a look at the data, you can kind of see that it's leaning towards cardiovascular benefits, but it's just not quite there to be statistically significant. So no CV benefits. It's not covered by the Ontario Drug Benefits, and I guess it would be extremely expensive, but we'll see if it gets covered. It would be nice. It would be a nice option for patients who don't want to inject themselves, right? So moving on, that pretty much concludes my presentation. That's all the information that I think would benefit you the most. I just want to end this presentation by reiterating this is a team effort. Look at all these different factors that we got to consider. Look at all these different factors, right? No individual healthcare provider could possibly manage all of these factors at the same time. So this is a team effort. Every part of the healthcare team has their own set of experiences and perspectives and expertise, and they're all going to play a really important role in taking care of these patients, of these very, very complicated patients, and ensuring that they have the best chance of getting a good health outcome. We all have a role to play, absolutely. So thank you guys for listening. Very much appreciated. If you've watched the entire video, I thank you so much for watching. If you have any questions or concerns, let me know in the comment section below. I very much appreciate criticism of the constructive nature, constructive criticism. If your criticism is just talking trash, then you can keep that to yourself. But if you have some constructive criticism, I would very much appreciate that. Feel free to let me know. Thank you guys again for listening. Hope you guys learned something new. Hope the jargon was not too much for you today. These are my references, and I'll see you guys in the next video.